and additionally for the healthcare workers who are looking after them. This is a period of maintaining the gains that we've made. It may feel to a lot of us like limbo, but I can assure you that it's not. Charting a way out of where we are now with COVID-19 will be very challenging, and perhaps even more challenging than the way in. But the way that you as Australians can help us meet that challenge is to actually stick with us, stick to the physical distancing restrictions that we've got in place, stick to the hygiene advice that we have been providing to you, doing all the things that Australians have been doing to help lower those case numbers, and they remain low today. And as we, as the health advisors to government, deeply and thoroughly explore the options and consider how the virus may behave in our community as those various options are considered or implemented. And whilst it's good news again in terms of the total numbers, we acknowledge that there are Australians in a region of Australia in northwest Tasmania where the case numbers are increasing related to the hospital outbreaks there. And it is a sobering reminder of the realities of a new virus in a community where there is no immunity, that virus can behave unpredictably and that we are not immune. The Tasmanian government is doing everything in its power to ensure that Tasmanians in northwest Tasmania have ongoing access to medical care, and the Commonwealth has been assisting, and there is an Australian Medical Assistance Team, or AUSMAT, supported by the Australian Defence Force, who are ensuring that emergency care can be maintained in the northwest of Tasmania, whilst many staff are isolated and in quarantine. And I'm happy to take questions.
From a health perspective, has the World Health Organization got the ball on wet markets and do they need to close?
Wet markets have been a contentious issue with regard to infectious diseases for longer than the COVID-19 outbreak. There have been calls for many years for their regulation, and there is evidence in the current outbreak that wet markets may well have been involved with the inception of COVID-19. So I suspect those calls are not new. They will continue, and the regulation of wet markets will be a matter for discussion with the World Health Organization and those governments where wet markets are prevalent.
Your colleague Michael Kidd this morning said that if you have symptoms of any kind, like a sniffle, runny nose, you should go seek a test. Now that's not currently the advice on the website. What are the specific requirements for getting a test? What symptoms do people need to be displaying to go get one?
Okay, so let's bring back to the principle that when you will definitely get a test is if you have cough, fever, respiratory symptoms, and you're hospitalised. That is clearly on the Communicable Disease Network Australia website. However, it's been very clear from the Deputy CMOs and the CMO and Chief Health Officers around Australia that public health units now need to pivot towards a broader testing regimen. So that whilst the national guidance remains the same, there's certainly individual public health units that are taking a broader view of the symptoms that might be required, and maybe we should say milder symptoms can get you a test in some jurisdictions. A good example was the Bondi Beach pop-up clinic that happened a week ago in response to outbreaks. So that's actually part of a nuanced approach which reflects the difference in density or of infection around Australia. So that's what my colleague was reflecting on this morning.
Just back on the WHO story, obviously with the wet markets, that's just something that's happened that as well the US has said that they're going to pull funding. Is there beginning to be an erosion of trust there in that national body, and also inconsistency internationally regarding how much that body will be listened to and trusted?
Well, when there's a pandemic affecting every nation in the world, one needs a multinational organisation, and the Australian government, you've heard today, 100% backs the role of the World Health Organisation in providing a key role in managing this COVID-19 pandemic.
Dr. Coatsworth, as states now look to potentially encouraging teachers and therefore students to return to school, could you provide what the latest research, advice, case examples are of both potential child-to-child transmission of the virus in a school environment and also teacher-to-child transmission? How prevalent is that, or is it remaining the case that it's not a concern?
This virus is a very challenging one conceptually for any parent or teacher that goes through any winter period where their children bring home respiratory viruses and they circulate within the schools. There is something different about COVID-19. It quite clearly affects a lower proportion of children, and we know in Australia that about 136 children between the ages of 5 and 18 have been affected, representing only 2% of our total number of cases. So those raw numbers alone demonstrate the lower propensity or likelihood of children to get infected. In terms of the potential outbreaks that have been associated with in schools, it's also clear through investigations in some jurisdictions, New South Wales, South Australia, that single or one or two cases of child-to-child transmission or teacher-to-child transmission have not resulted in the sort of widespread outbreaks that we've seen amongst adults, either at weddings, for example, or indeed in our elderly population in residential aged care facilities.
Continuing on the issue of schools, obviously there are concerns about the workplace health and safety of teachers. Would the AHPPC be in a position to consider specific kind of practical measures that schools could implement? Will that be left exclusively to states? Do you see value in there being a nationally consistent set of advice and guidelines given to schools?
So it's the view of the Australian Health Protection Principle Committee that schools are safe places because of the low rates of transmission. However, I can confirm today for you that the AHPPC has indeed been considering how to make schools even safer for staff, for teachers in their such essential role in this COVID-19 epidemic, and that advice is being considered by National Cabinet this week.
Ask on the app that is being developed by the government. Who will it be intended for? Like, would you have to be tested positive to be part of the tracking? Does it need a particular take-up rate to be effective, and is it a replacement for human contact tracing?
So I'll address the last question because I think it's most pertinent. It's certainly not. The contact tracing app is not a replacement for human contact tracing. It's designed to, you might say, be a force multiplier for the already hundreds of contact tracers that we have in public health units to streamline the contact tracing. What the app would actually do is be able to determine who you had been close to for greater than 15-minute period, which is what we define as close contact, through Bluetooth technology, and that information would be stored locally and privately on an individual's mobile phone, only to be released if the person became COVID or was diagnosed with COVID-19. So with that in mind, you can imagine that contact tracers have to call individuals, and their recollection of contact might not be perfect, so it provides an added information technology source of that information so that the contact tracing can be even better than it already is at the moment.
Thank you. Could I ask two slightly technical questions? What can you say about the current effective reproduction rate? I think it's called the REF. What level are we aiming for? Is it level of 1? Are we below that now?
The idea of the effective reproductive rate, or R0, in this sort of epidemic is that if it's below 1, the numbers of cases, the prevalence will gradually decrease, and if it is above 1, you'll get increases in the number of cases. And that R0 that we did our additional modelling on was around about 2.6, 2.7, which was the international experience, leading, as you know, to the really challenging scenarios in the New York Italy, etc. So given what we know about the behaviour of the virus at the moment, the R0 is likely below 1, but that is being determined, and one of the challenging things about understanding our R0 is that so many of our cases are travel related and so much fewer of them are community related. So we need almost to have a little bit more time to work out what our R0 is, but the overall principle is that the curve is flattening and that the measures that Australians are coming on board with are actually working.
With regards to the outbreak in northwest Tasmania, and it's the first, I suppose, broader scale example of this rings of containment idea where you have a widespread but localised shutdown. Is that a model that would, in the opinion of the AQC, be best applied if there were outbreaks in other pockets, like specific parts of Sydney or specific parts of regional Australia? What lessons are you hoping to take from the management of that outbreak that could be applied elsewhere?
Well, I'd say that the outbreak is in its very early stages, and the control and investigation of how the outbreak occurred are in the very early stages. As a model, it is forming part of a classic epidemiological investigation, and all the measures that we're doing are exactly the ones that we've advised: isolation, quarantine, and then there'll be a reintroduction of staff back into the hospital. So should there be outbreaks in other parts of Australia, the response will be dependent entirely on where that is. Obviously, outbreaks in very well-resourced urban areas compared to remoter areas or rural and regional Australia areas will engender a different response that will be tailored to give the best access to care. I'll just move over this one.
You said we're going to need more time to understand that sort of community transmission. How much more time before we understand how that's tracked?
Well, you can certainly get an R0 based on the number of community cases that we've got. It's whether that represents something that's accurate or not, because the lower number of cases you have, the less accuracy you'll have there. The most important thing at the moment is actually what the curve is doing and the number of cases, which is continuing to be very low, and the percentage number of cases, the new cases as a percentage of the total, continues to be very low. So you can infer success of our measures based on those numbers.
Dr. Cogsworth, is there any merit to having the fees waived for nurses who are currently out of work to encourage them back into the workforce, and any that have let their registration lapse? Have we put at risk losing those nurses?
Look, I think that's probably a matter for the Australian Health Practitioner Regulatory Agency to answer. What we do know is that there are a large number of nurses within the Australian workforce that don't actually practice frontline clinical nursing, and a lot of those have put up their hand to be able to come back and be part of the COVID-19 response. So that's a fantastic outcome.
Could we possibly see teachers in schools being issued with some kind of PPE? Would that be practicable? Is that something being considered by National Cabinet or by the Health Advisory Board?
Look, I think what we've got to remember is personal protective equipment is the last thing you use in your risk mitigation strategy. It's not something we've considered for schools, because there are a whole range of risk mitigations that you can put in place before then. The most notable that's been put in place at the moment is that schools are closed, and it's the Easter holidays. So no, we're not considering that at this point. But what we would say as well is that whether you're a teacher or a parent with a child who's sick, any sort of respiratory symptoms, you have to stay away from school. That's the base level of protection that we've got.
Just on the issue of children and the role of children in transmitting the virus, what does the data say so far, and how many children have been confirmed cases in Australia?
So as I said, it was 136 children between the ages of 5 and 18. That's the data that I can give you today. In terms of transmission, there's been some detailed investigations done by the various jurisdictions that I'm going to let them comment on specifically, but there are not large outbreaks within schools as a result of those. So as I said before, that's an important indicator, because you can contrast that, a single or 2 cases at schools does not appear to lead to large school outbreaks. However, in the adult context, when you get cases, they are clearly leading to more significant outbreaks, and even more so in the elderly, which is why we're so concerned about our residents of residential aged care.
Can we rule out new cases coming out of schools, given that we're one of probably or possibly one of the few parts of society that will be back up and running in some sense, if that's the decision by National Cabinet tomorrow?
No, it's not possible to rule that out at all, and it's clear from what I've just said that there will be cases amongst children. The question becomes how many of those are actually going on, and what transmission happens as a result of that. And it seems, from what we understand at the moment, that transmission is very low.
Can I just ask you, from a perhaps personal point of view, how would you encourage, or what would you say to Australians about the app that's being proposed? Why should they take it up? Should they have privacy concerns?
Well, I can say, both from a personal and professional point of view, that the way forward with COVID-19, living in an environment where we're not immune, is entirely based on building our capacity within the health system and our capability to detect the cases. So the app will offer an enhanced capability for case detection and interruption of those transmission chains. And with any sort of infectious disease, that's our fundamental weapon at the moment, absence of a vaccine. So if we have that weapon, we need to closely and carefully consider its merits, particularly in relation to privacy. We couldn't agree more, but that it is a potential important tool at our disposal.
Should a more cautious approach be taken on schools until we know exactly how much of a role asymptomatic children play in spreading the illness?
Asymptomatic transmission is a key point of investigation. So that is being looked at by public health units around Australia. And I think what you're seeing at the moment is certainly a demonstration of that cautious approach. So I'll take one more question now. Exhausted everyone. Okay. Thank you all.